We all do it every day. We breathe in, we breathe out. Effortlessly, we don't even think about it. Naturally, the air just comes in and comes out. But today I'm going to explain to you those volumes of air that you breathe on a breath-to-breath basis, what they're called, and I'm going to give you a visual depiction of those breaths. So let's jump right in. Here you see a diagram that expresses all of our total lung capacity, everything that the lung can take in, out, and all volumes that are in the lung at all times. So quickly I'm going to just explain that the upswings here are inhalation, and the downswings, exhalation. So with that being said, here we're going to start with normal breathing. This is called your tidal volume. This is the normal breathing that we do all the time. Then you'll see this large upswing inhalation. This is called your inspiratory reserve volume, and this is basically you breathing in the deepest breath you can, filling your lung. After that, you're going to have an exhalation, and if you continue beyond normal exhale, all the way out, forcefully exhaling, you're going to be blowing out your expiratory reserve volume. This is the amount of air you can blow out all the way till you feel like your lungs are empty. But you may notice there's still a volume here, this residual volume. This is a volume of air that stays in the lung at all times. You can't breathe it in or out. It is air that stays there and stints the lung open so that it doesn't collapse. So, everything that you can breathe in and out makes up your vital capacity. That's the air you have control over in your lungs. All of it together with that residual volume, total lung capacity. There are two types of lung disease that can affect those volumes. There's a restrictive lung disease and an obstructive lung disease. First thing I'm going to talk about is the restrictive. This is a nice diagram of a restrictive lung disease, scoliosis, noted by S-shaped curvature of the spine. As you can see here, that curvature of the spine restricts and compresses the lung, so it's a restrictive lung pattern. This is what occurs inside the lung when you have a restrictive lung disease. You'll notice this is a normal lung on the left, and this is the restricted lung here on the right. And this restricted lung is smaller than the normal lung. That is on purpose. It is supposed to be that way because it is just like I explained, it's restricted, it can't expand to its normal volume. So what you see here is all those lung volumes are decreased, noted by the down arrow. Next thing I want to talk about, and more importantly, I'm going to focus on this a little more, is obstructive lung disease, especially COPD. The reason I want to focus on this is because COPD is the most common obstructive lung disease. It was the third leading cause of death in America in 2010 and still continues to claim the lives of millions annually today. The number one cause of COPD, is smoking, and because of that, it is completely preventable. This next slide is a picture of what your lung may look like if you smoke. Not very appealing. Here are some of the symptoms that occur if you have COPD. You're going to have shortness of breath, especially on exercise. You're going to have chronic productive cough bringing up lots of phlegm. You're going to have wheezing, which is an adverse breath sound that you hear in the lungs. You're going to have chest tightness, which is very uncomfortable and causes lots of anxiety. And these patients are going to be prone to recurrent respiratory infections. What you'll see next are the physiological defects, the things that occur inside the lung when you have COPD. The most important aspect is it causes a loss of elasticity of your lung. So basically when you breathe in and out on a normal basis, your lung acts like a balloon, inflating and deflating, recoiling back to its normal shape. With COPD, you lose that, it's damaged, it can be hyperinflated, and it doesn't go back to its original shape. The second thing is the lining of the lung becomes inflamed and increases its sputum production, which further decreases the basically the lumens, the passageways for the air to flow through the lung. Together, these two defects cause pockets of air to be trapped and hyperinflate the lung and keep it that way. That hyperinflation is due primarily to an increase in the residual volume. If you remember from the first slide, the residual volume is that trapped dead space volume that keeps the lung open but isn't usable to you, doesn't help you in any way. This causes an increased work of breathing and shortness of breath. What you see here is, again, a nice depiction of a normal lung on the left and the obstructed lung on the right. I want you to notice a few things. First, this lung is larger than the normal lung. That is on purpose. That's because of that hyperinflation over a distended lung. The things to note here that are key also is the fact that most of that hyperexpansion is due to an increase in the residual volume of dead space that you can't use. Because that space is increased, the vital capacity, which is everything you have control over, breathing in and out, is decreased. That increases your shortness of breath and raises your work of breathing. This is a nice X-ray photograph of what we have with a normal lung versus a COPD lung. The things that are key to note here: the normal lung takes up less of the chest cavity than someone with COPD. The lungs are larger and hyperinflated. Then the second thing to notice, right here, this is your diaphragm, and it is a dome shape. That's what it's supposed to look like, and the lungs curve around that diaphragm. This is the major muscle of breathing, and when it's domed, it acts as a plunger, helps the lung breathe in, breathe out. Over here with COPD, you'll notice there's much less of a curve, almost flattened the diaphragm. That's because that hyperexpanded lung that doesn't go back to its normal shape presses down on the diaphragm. Therefore, increases the work of breathing and shortness of breath that you experience with COPD. So we've discussed the breath-to-breath basis, volumes of air that are inside your lung, from normal breathing to your deep inspiration of inspiratory reserve volume, full exhale, expiratory reserve volume, that residual volume that stays in the lung at all times. We've also hit on the two main types of lung disease that affect those lung volumes: restrictive, where everything is decreased, and then obstructive, which is completely preventable. And the number one cause is smoking, so if you never start smoking, you don't have to worry about having COPD. So hopefully you've enjoyed this presentation, and hopefully you've even learned something. Thank you for watching.